Hi, everybody, and welcome back to what I just learned is the 50th episode of Rapping with the Rep. I'm here with my friend, Representative Jeff Roy from Franklin.
Great to be here, and congratulations, 50 episodes.
Thank you very much.
That's incredible. I can't wait to see what kind of a cake they bring you.
Yeah, I'm looking forward to that too. In fact, my very first guest was the chairman of Healthcare Finance. The House chair was Steve Walsh.
Wow.
We talked about healthcare, the law that we had just passed in 2012 at that time.
Sure.
And it turns out Steve later took a job with Mass Hospital Association,
Yes.
right here in Burlington. So apparently he came on Rapping with the Rep. He liked what he saw, stayed a while. So, you know, you can look around.
So he's going to be watching this show, so I have to be very careful with my answers.
He will be. So there's a lot of implications to this.
Sure.
Representative Roy is a classmate of mine, which means we started in the legislature at the same time. And for both of us, we're beginning our fourth term. And it's been an interesting and wonderful ride
Right.
serving with you, and really a pleasure serving with you, one of the smartest colleagues that I have in the legislature. And Jeff is the acting chair of Healthcare Finance. And I think many of you know that one of the challenges that we have here in the Commonwealth, one of the most significant challenges, is how to fund our healthcare. Here in Massachusetts, where we started the universal health care, showed it as an example to the rest of the country. It then became the ACA, or what some call Obamacare, or the model for the ACA. And now we're in another period of transition, both locally and throughout the nation. So Jeff, let's talk a little bit about where we are now with our healthcare challenges, and then where we're headed. So
Sure.
talk about where we are now first.
Well, I think putting it in a historical context, going back to 2006, when Massachusetts became the first state to offer universal health care. And the goal was to get coverage for everyone in the Commonwealth of Massachusetts. And over the years, we have succeeded to the tune of 97 or 98% of all of the people in the Commonwealth of Massachusetts are covered. That's 6.4 million people in our Commonwealth.
And that's the highest in the nation.
Highest in the nation. And you know, the states are meant to provide experiments so that other states can see what's happening there, and certainly President Obama saw the great success we were having, and Obamacare was modeled after what we've done in Massachusetts. And you know, when you take on a responsibility such as providing universal health care, obviously it's going to have some impacts on your healthcare system as a whole. So over the years, we've been engaged in some tweaks or changes to the healthcare system to adapt to some of those changes, and adapt to some of the things that we may not have foreseen. And so we continue to do that along the way. 2010, we had to make some changes to adapt to what the federal government was doing. We did that. 2012, we had some more changes. And during my year as the acting chair of the Healthcare Finance, we were attempting yet another series of reforms to the system. At all times, the goal is to increase access to care, and that's what providing universal health coverage is all about. But at the same time, we have to be wary of the costs. And you know, up until last year, Massachusetts was the highest cost for health care in the country. As of last year, Alaska has overtaken Massachusetts. What we did with our 2012 reforms was to try to rein in those costs and come up with a cost benchmark, which you know, provided a percentage that most providers and hospitals had to keep within that 3.6% benchmark.
Right.
And I'm happy to report and happy to say that we have done quite well in maintaining that benchmark. The adoption of the Health Policy Commission and CHIA, which is the Center for Health Information, I don't know what the A stands
It's
for,
association, maybe,
so that's an organization that is looking at data that they can translate into policy recommendations for us. So between Health Policy Commission, CHIA, we're getting some good and valuable data and information that's helping to inform our decisions. So what we were going to look at in 2018 were things like telemedicine, digital health, making more use of electronic health records. We were looking at greater transparency in the system, making it easier for consumers to access medical care, getting better pricing information to consumers of healthcare, having them act as ways to help us control the cost of healthcare by shopping around for services. And that's required some tweaks in terms of giving more information to consumers, getting better data about who are covered doctors in their health plans. I think one of the things that we've seen is this growth of surprise billing or out-of-network billing, and I think the most common scenario is someone goes to an emergency room, they show their health card at the door, and they're referred to a specialist. And you know, when you're laying on a gurney in an emergency room, you're not asking questions like, well, let's make sure that specialist is in my health plan. Those types of conversations are not taking place.
Right.
You get your care, you're on the road to recovery, and 3-4 weeks later you get this
Massive
several
bill.
$1,000 bill, which you learn subsequently that the specialist that they referred you to is out of your network. So we wanted to do some ways to control out-of-network billing and greater transparency overall. I would say that this year's bill was addressing consumers, and it was a very consumer-friendly bill. The other piece of it that was a major piece was trying to aid community hospitals. Some of the smaller facilities that were not parts of these larger groups, but they provide a very valuable service in their community, having access to an emergency room and medical facility to address them. They're struggling with rates of reimbursement and ways to recover for all the expenses they incur. So we wanted to offer some relief to the community hospitals. A huge package, 180 pages in total by the end of the day, but I think some great steps that we were attempting to, again, increase access to care and rein in costs.
Yeah, so when we're talking about the community hospitals, and you mentioned the reimbursement rates, one of the challenges that our hospitals, especially in what we call the gateway communities, which are, for example, Lawrence or Brockton or Holyoke, some of these places, they've got a large percentage of people who are coming in on Mass Health, and Mass Health is publicly funded. And so the care isn't getting reimbursed in the same percentage as it would be from Blue Cross or Tufts or Harvard, Harvard Pilgrim, one of these others. So we've got to look at how to level the playing field a little bit so that these facilities can stay vibrant in business, so that they're available. And they're not for profit, but they stay there available for people to get their care.
There's this concept of provider price variation that has really hurt the system. So, for example, a knee replacement. You know, everybody believes that, you know, the best place to get a knee replacement is one of the top hospitals in the city of Boston. We're not here to make any comments about the quality of care at any facilities, but it's quite expensive. So a knee replacement at one of the major hospitals could run, you know, $35,000, $40,000. That same level of service could arguably be completed with the same level and quality of care out in one of our community hospitals in the range of $10,000 to $15,000. That's the difference between the negotiating power of some of our bigger systems in the city and our community hospitals. And the bigger providers have been able to leverage their weight and charge exorbitant rates for the same type of service and quality of service that you can get out in these community hospitals. And so what we have been trying to do is try to steer people to the lower cost, same quality care in an effort to drive down the overall cost of health care. And I think what you've seen is this notion of shared responsibility. So most people who are probably watching at home have said, well, I've seen my co-pays go through the roof. I've seen my out-of-pockets go through the roof, and it seems that I'm paying more for health care out of my pocket. Well, there is a rationale for that. It's to try to give you as the consumer some skin in the game so that you're going to shop for the same quality of service. We don't want you to compromise on your health and safety, but shop around and find a better way to do it. So it's our responsibility to try to provide that information as to where people can do it. And we're constantly urging the health insurers to help their consumers to shop around and offer them some incentive to go and get treated at the lower cost place. And that provide a price variation is something that has really has hampered us, and that's something that we're trying to address with the legislation.
It's a difficult issue because with a lot of public policy, there's a balance that you have to go through. So some people will say, and you hear it especially nationally, well, you can always have the doctor of your choice. I still want to have my doctor. Okay, but what if your doctor is in one of the teaching hospitals in Boston and is very expensive? You can have your doctor, but who's going to pay for it?
Right.
And to some extent, the answer will be you can have your doctor, but you'll have to pay a little bit more for that choice. A lot of that philosophy comes right down here to Leahy Health Center here in Burlington, because they've got their facility here in Burlington that to some extent is used for very sophisticated performing sophisticated medicine. They can send that same patient to one of their satellite hospitals or to one of their outpatient facilities and have that same procedure done much less expensively, and they'll tell the patient just that, their consumer just that. Look, we'll send you to another place. We'll get it done, and it'll be done wonderfully. You'll go to Peabody, you'll go to Lexington or one of these other places, and we can do that, but we don't have to tie up this space that we could be using for someone who needs that space for something more sophisticated.
And sometimes offering some sort of a financial incentive to that person is helpful, or providing them with a facility that's closer to their home so that they, family members who want to visit them don't have to drive far. They don't have to drive into the city to see them. Another approach to this whole problem, and it's something that was rolled out in 2018, is the ACO model of care. And Mass Health has 17 ACOs among its system, and they've transferred approximately 600,000 to 700,000 of their Medicaid recipients, the Mass Health recipients, into the ACO model. What is the ACO model? For folks at home are probably saying, well, it's a more holistic goal of addressing health. So first of all, everybody gets a primary care physician, because we know from the analysis that we've done that just by virtue of the fact that you have a primary care physician lowers your overall health care costs.
Sure.
So let's get everybody into having a primary care physician. Let's offer them services in their community through community health centers. Let's offer them things like nutritionists. It's amazing what diet can do to your overall health. Looking at your living conditions, where you live, the type of environment that you live in has an impact on your health. The social determinants of health are really playing a role in that ACO model, and what the ACOs are being given by Mass Health is they're given a lump sum payment per individual enrolled in their ACO, and that is to cover their overall health care costs, everything from primary care to nutrition to physical therapy to surgery. It's all treated under one lump sum payment, which provides an incentive for everybody participating in that system to watch how you're spending your healthcare dollars. It's a fascinating model. I'm very interested to see how it rolls out practically and the overall impact that we'll have on the system, but I can't see how it won't have a positive impact.
Right, as long as the patients are distributed, the patient base is distributed evenly, so that you have some young people who the cost will be somewhat low. older people as we become more ill later on. There'll be more of an investment in that. But you're right. The incentive for a healthcare facility to keep you healthy becomes something that they benefit from and you benefit from.
I say that to folks all the time. Do you want to lower costs? What's the best way to lower costs for our system? Keep people healthy.
Right. And in fact, what it also addresses is the pay-for-service model that we've had, which is if the healthcare center is paid more for this test than that test, there was a time when they would order those tests.
Right.
If it was close, just order it. They'd get paid for it.
And most people who were receiving health care 10, 20 years ago weren't caring about what cost was associated with that particular service, because I have health insurance, they're going to pay for it, so I don't have any incentive to do anything other than seek the highest cost. Well, we all assume the highest cost is the best care. That's not necessarily the truth, but you didn't have any incentive to look elsewhere, and that's a major shift that we're seeing taking place in healthcare today.
Now, I know there are some businesses, people going out to work, they're the lower paid workers, and the businesses are advising them to get onto Mass Health, and they could perhaps help them with that. But Mass Health is taxpayer supported, so we're paying part of those costs. What are we doing, if anything, to address that situation where people at one point would have had private health insurance, but it's less expensive for these employers to provide their employees with health care that way?
Well, we are definitely trying to keep track of those companies that are shifting people into Mass Health. Prior to 2010, when our healthcare package originally this was before Obamacare, you were prohibited as a consumer from going on to Mass Health if your employer offered you health insurance. You had to take the health insurance offered by your plan. When the ACA came into effect, we had to do away with that particular provision in Massachusetts law. We brought back a HERD form that employers have to fill out telling us about the benefits that they offer to employers. So we're tracking that data. What we'll end up doing with that data remains to be seen, because we just started collecting it in the last year. But one very positive aspect that we've done is we've introduced the Health Connector for Business. And this allows any small employer in the Commonwealth of Massachusetts, if you have anywhere from 2 to 50 employees, you can offer great health insurance to your employers. Now, for example, I was talking to a local coffee shop owner in my community just a couple of weeks ago, and he was talking about the difficulty with the EMAC assessments that employers were getting if their employees were ending up on Mass Health.
So talk about the EMAC assessment is an assessment because, like you said, of an employer using the public health system.
Right. If your employees were going on Mass Health because you were not offering health insurance, then you were being assessed from the Commonwealth of Massachusetts an amount to cover the costs associated with that person becoming a public payer.
So that the taxpayers weren't essentially reimbursing that.
It's a heck of a lot lower than what you would have to pay if you offered that person a health package, a health plan. But it's a necessary element in order to make this system work as a whole. But when I was talking to this particular employer about his EMAC assessment, I introduced him to the concept of Health Connector for Business. And here's a way that you can offer a silver, gold, or platinum package of health insurance benefits to your employees using the top health insurers in the Commonwealth, the Blue Cross Blue Shields, the Harvards, the Tufts, all the major players in the health insurance business are part of this Health Connector for Business pool. You can set the amount that you want to reimburse. So if you say, I'm going to pay 50% towards my employees' health care, that's your contribution, and it can't go any higher. If your employee wants to get a better package of benefits, a gold or a platinum, they can pay the extra money to get those extended benefits. It allows you to offer a tremendous benefit to employees, even if they're part-time employees, and it gets you away from any EMAC assessment, and gets more people into the private health insurance market, which is where we want people to be, so that the system has a huge pool to draw from.
Yeah, and that's a real cost saving.
Yeah, and it's great because it's small employers, 2 to 50 people, have access to insurance that 10 years ago you couldn't touch as a small employer.
The one area of medicine that this will help, that the ACOs and what we've been talking about, is mental health care. Because when someone comes in and sees a primary care, they may discover that there's an untreated mental health condition that maybe someone can benefit from, including substance abuse.
Right.
Get someone like that into the system and think of all the problems that you could solve that could come up later.
Right. It's a tremendous opportunity to further improve our healthcare system. And you know, we've talked about multiple components and pieces, but they all are part of the overall healthcare system. And you have to address each system. If you move one piece of the system in one direction, or you pull one piece of the puzzle away, the impact on the other side is incredible. So it's keeping all those pieces together that's extremely difficult.
Yes, that's what we were talking about, the balancing act. It's easy to make simple talking points, especially when we're in public service, but it's not always so easy to carry out. And so we have to be very careful in the things that we do and say, because of the cause and effect that you create when you move these parts apart. Now, one of the areas that we've been looking at, I know, is the high cost of emergency care and the number of people who go to the emergency room when they have issues that really don't need to be treated there. Adding to these networks that will provide primary care is certainly a way of doing that, because if someone can get into an appointment the next day with their primary care, who may say between 8 o'clock and 8:30 available, our pediatrician does that, and others who do that is great. You've met with me here in Burlington and in Bedford with urgent care, AFC Urgent Care. Dave Adams has shown us through their facilities, and that seems to be another way that people can keep healthcare costs low for themselves and for the system.
Right, the urgent care model is fascinating, and it's the type of care that's delivered in, whether it be in a mall or some storefront, you know, in your downtown. It's not necessarily at a hospital, but it's a storefront where you can go and get the routine care. Do you have an earache? Do you have a sore throat? Do you have a cold? Do you have something that doesn't necessitate emergency room care, that can be delivered in a convenient place at a much lower cost? And the business community has caught on to this. And they established a coalition earlier this year where one of the very things that they're tackling is the exorbitant cost of emergency room care, and trying to direct more patients to the low-cost urgent care clinics or their primary care physicians as a way to drive down the overall costs of health care. It's a cultural shift, because I think a lot of people believe that if you're in sick, you go to an emergency room, and there are other alternatives. First of all, in an emergency room, you show up with a cold or an earache, you're probably going to sit there for several hours before you get treated. That person who's coming in with chest pains is definitely going to take priority over you. But the urgent care clinic is a different ballgame. It's people like yourself that can go in there. Most of them are open for later hours, so that you don't have to you don't have to go in the middle of the workday. You can go there at 7:30 at night. You can go there 8 o'clock in the morning. So there are all kinds of arrangements, and weekends.
Yeah,
right. Yeah. It's a great system. I'm excited to see that the employers are taking a part and are actively encouraging their employees to have primary care physicians use the alternative types of care. And That's the type of cultural shift that we need to drive down the overall cost of care.
Jeff, you were very receptive when a group of the urgent care physicians and business owners came in to see you saying, you know what, this is a new model and we're not sure that there's been enough exposure to this.
Right.
And came into the State House, talked about it, and then you've gone out and seen some of these
Right.
facilities and changed the legislation that we were looking at doing to take into account what you were learning,
Right.
which is, you know, people sometimes overlook the fact that in the legislature, you know, we're looking for opportunities to learn more about how we can help our constituents.
Yeah, and I think in one of those situations, it was a constituent of yours
Right.
who reached out to you,
Yep.
and you in turn reached out to me, and we had an excellent meeting. We were able to get a better understanding of what they were doing and what we were trying to do, and arranging the visit to go out and actually see the facility. That's how you make good policy.
Right.
You understand each other, you talk, and you try to get in each other's shoes to understand where they're coming from. And you know, I'm hopeful that we're going to revisit health care in the next legislative session so we can begin to address these issues.
So let's talk about what happened then, because many of you may know that this was a bill that came up to the legislature. It didn't quite get it past the finish line.
Right.
In your opinion, can we get somewhere in the next session? I hope that you're named the chair. You've done the work that it takes to do that, and we'll see what happens in the next month or so.
Sure,
But what do you think?
I'd be grateful for the opportunity. I know that we came very close in reaching consensus on the healthcare legislation. So as you may recall, we passed it in the House in June of 2018. The Senate had passed a version in late 2017. And the job of us between June 20th and July 31 was to attempt to reconcile the House version with the Senate version. And I would say we got to the 1 yard line, but just were not able to get it over the goal line because we had a few sticking points, largely centered around provide a price variation and some other issues. But we couldn't get together. But I think we all understand that this is vitally important, that we have good frameworks on which to address these issues. And you know, we have players in place who can bring this to fruition. And my hope is that we can finish what we started relatively early in the next session.
Yeah, I hope we can too. I'm going to switch topics a little bit, and we may go a little bit over our 30 minutes, but I know the folks at home who are watching now will be interested in this topic, which is that you're the chair of the manufacturing caucus in the House. And here in Burlington and in Bedford especially, we have this vibrant high-tech manufacturing presence here. So can you tell me a little bit about what we're doing to support our high-tech businesses in the Commonwealth and what your outlook is for that?
Well, the one thing to make sure that folks understand, when we're talking about manufacturing, we're not talking about the dirty, dusty, dingy factories from 100 years ago. Those were great, and those were part of the building of the Commonwealth of Massachusetts, and they were part of what brought us to where we are today. But those types of factories pretty much don't exist anymore.
Not here, right?
Today, right. Today, robots are doing much of the work, putting things together and doing the finite details. And what we have evolving is called advanced manufacturing, where we need people who are talented enough to talk to these robots, to tell them to do the various things that we need. So you have that emergence of technology happening at the same time that you have entrepreneurs and innovators who are developing products and machines, and they happen to be in the MITs, the Harvards, the Worcester Polytechs, the UMass Lowells. We happen to be in an innovation hotbed. Right. And getting their products to market fast is vitally important to them. And I think they have discovered that inventing a product, shipping it overseas to China to be mass produced, and then taking it back has delayed getting product to market faster. So what the innovators and the engineers want to be close to their manufacturing facilities. So you've got the convergence of that idea with the uptick in advanced manufacturing, and Massachusetts happens to have the greatest ecosystem to bring those two forces together.
Yeah.
And what we're seeing is a renaissance in manufacturing here in Massachusetts. And we're offering tax credits for apprenticeships, we're offering equipment grants and loans and workforce training for employees to get the skilled workers into these factories to take advantage of this combination of technology and need for getting the products to market faster. And Massachusetts has benefited wildly from this renaissance in manufacturing. And I know your area of the Commonwealth of Massachusetts is one shining example of that.
Right, because one of the ways that this comes about is, as you said, we've got these scientists coming out of these large, the Institute, the MITs, the Harvards, the BUs, the Northeasterns in our district. They've got a presence here in Burlington. At the same time, we need workers to staff other jobs in these businesses.
Right.
So there you've got a place for people coming out of the community colleges, people coming out of our technical high schools, going straight to jobs, and there's a great desire. I spoke with one of our large employers, large high-tech employers, just a few weeks ago, and I asked him, what can we do to help? He says, we have this need for essentially the middle tier of our employment opportunity or expansion. We need people coming out of our community colleges, and if we can have some meetings there and tell them what we're looking for, us people with associate's degrees. We need people from all different backgrounds to come in because, like you said, we want to keep the process here. Right. And so we need people at all of these levels to staff the office jobs, to staff the, the facilities jobs.
Right, and people who can run these machines. This is highly sophisticated CNC machining that's translating drawings into robotic work, and somebody who knows how to do that is vastly in need. So we're looking at things out in Central Mass. There was a group of companies that came together called MacWick, and they put together a whole curriculum of educating people beyond a high school diploma, not necessarily a bachelor's degree, but something in between. Right. And they came up with a 6th level of certification that employer base could say, if they have this level of certification from MacWick, we know that they would be perfect for this job. We're trying to get that on a statewide scale and having some credentialing and certification that employers can rely on, and that people who may be underemployed, who are looking for something that they can do in a lucrative job and something that has a future, but they don't necessarily want to go all the way to a bachelor's degree. Those are the types of things that we're looking at, not only in the Voc schools, we're even looking in the traditional public schools, high schools. We're even looking at kids at the middle school level to drive them to this area and trying to convince their parents that manufacturing is something that they really should be looking at.
Yeah, in this area too, what's exciting about that is that these are opportunities that didn't exist several years ago. Right. And so someone who wants to go into these areas now don't have competition from someone that has been an expert in this field for the last 20 years, and so therefore it takes a long time to climb up that ladder, because the ladder is just being made right now.
Right. We have a lot of people who are retiring and leaving the industry because they're older and they have tremendous skills, and we're losing those skills, and so we need new people to come in and take over those skills.
As well as, like you say, mid-career people who experience layoffs and now can find their opportunities that previously hadn't existed, and if they take, take this training and get into that, there's a lucrative position for them now.
Yep.
Well, Representative Jeff Roy, I appreciate you being our guest on our 50th episode of Rapping with the Rep. We went a little long, but for a 50th episode, I guess we can do that. But folks, thank you for tuning in. We'll see you next time on Rapping with the Rep. I'm Representative Ken Gordon. Thank you.